Hi, my name is axSpA. I'm Associate Professor of Medicine and Epidemiology at the University of Pennsylvania in Philadelphia. And today I'm going to talk to you a little bit about sex differences in patients with axial spondyloarthritis. So this has been a hot topic over the last several years with a number of different posters and abstracts presented at the meetings, but also papers recently published, at least in the last several years. There have been a lot of interest in terms of disease susceptibility and disease outcomes in axial spondyloarthritis. So some of the first pieces that were noted to be different were the prevalence of axial spondyloarthritis among men and women. Long ago, when we were thinking just about ankylosing spondylitis or radiographic axSpA, we really thought this was a male predominant disease. And it still remains more men than women that have true ankylosing spondylitis by modified New York criteria, for example. However, as we broaden that group of non-radiographic disease, the male to female ratio there is much more similar. So it's near 1-to-1 in radiographic disease, in non-radiographic disease. Additionally, the prevalence of HLA-B27 in those two groups has been different. So the patients with radiographic damage in those male predominant groups have been much more likely to be HLA-B27 positive, where that non-radiographic group is much more likely to be still have higher prevalence of HLA-B27, but less likely to be HLA-B27 positive than the radiographic group. So there was a very interesting paper just published in Nature Genetics recently. And in this paper by Dr. Lee and Matt Brown and David Evans are the last authors on this paper. They found that there was a genotype by sex interaction in ankylosing spondylitis. So even in those radiographic groups, in ankylosing spondylitis as defined by a code in the UK Biobank. So they found that HLA-B27 didn't have the same benefit in terms of the likelihood ratio for development of axSpA in women as it does in men. So some really interesting things to follow up on there. They aren't really sure why they see those differences, but they do see those differences there. So maybe suggesting a hormonal aspect of disease or other expression of certain concomitant alleles that might be helpful in actually fulfilling the phenotype. So not only is there a sex difference in the expression of ankylosing spondylitis, we know that among patients with axSpA, that patients who are men are more likely to progress to have radiographic damage. There was another nice paper in the last year or so in arthritis and rheumatology, examining the shape of the pelvis and how the shape of the pelvis differs between men and women and may have an influence on the likelihood of radiographic damage, which is also kind of an interesting concept to think about. Next, we know that patient-reported outcomes are worse in women than in men. And another new study in arthritis care and research recently demonstrated that even over the long term, these characteristics of having worse patient-reported outcomes continue even over 5 or 6 years. The only difference in the men that was worse is that the men tend to have a higher CRP over that longer period of time, as opposed to women who tend to not have, are less likely to have the elevated CRP. In addition, from studies that we've done within the Corrivitas registry, we've also found that women with axSpA were more likely to have depression and fibromyalgia. And as you might expect, then women in general have been thought to have less persistence on therapy in axSpA, suggesting that maybe the therapy isn't working as well for them. So there's a number of reasons that sex differences exist in axSpA. There's potentially the shape of the pelvis, potentially genetic expression, and maybe that's hormone mediated. I think there's a lot to learn about that. But there are also worse outcomes in terms of clinical outcomes and higher prevalence of depression and fibromyalgia or central sensitization. So clearly there are differences. How does that shape how we treat the patient? I think that's something that we need to fold into how we care for patients and really assess what's going on at the time and what that particular patient needs and what their therapy goals are. So lots to learn, and I hope that we'll be learning more about this in the next 5 years or so. Thanks so much for your attention today. Have a great rest of the day.